Yeah, totally. I thought you meant into or something.
You have 5 minutes.
Awesome, that sounds good.
Let's see.
Yeah, and that was a lot more. Great. I don't yeah, I'm already here. I don't know why this tells you that I'm like, oh, that looks interesting. It's a girl.
I know we
Okay. Guys, for the people that are in the audience, now is a good time to come up if you have any questions that you'd like to ask the panelists that are here so far as we're waiting for some of the other panelists to come in. So from 6 to 6:30, so this is that window to ask any sort of questions that you like from our panelists, and they're happy to answer any questions. Okay, so come up as you'd like and ask away.
Well, that's because we were waiting. Yeah, I think last week.
A second. I mean, if I gotta look up business management. Keep going. This morning we're gonna do something. Hey, you repping that? You never guess what he's in.
Hi, Steve, how are you?
Like, all right, well, I'm gonna move around. And he's like 40 years. Yeah, so I was like, that's fun. Yeah. And I mean, there are some. I don't know. I stated
I know where it is. It was in my head to bring the college.
Well, we've got to check it out.
I told him. I mean, I guess I. It's not that deep. We can use my computer if you want, since this is
Yeah.
Does it mention because still on it? Did it say anything about not being?
No, it's a Neuralink.
I'm just making sure since he said like updated. He's like a co-PI, but Mion is my PI. I just use Welch. Yeah, I just sent an email to the other three panelists, kind of like.
Yeah, they confirmed, and then I sent a follow-up as well, confirming.
Yeah. If anything, meetings might be running, but it's good that we have the 30 minutes.
Yeah, no, that's right about it. That's right about it.
Yeah, and the live stream's running. So
Where's the live stream going to?
YouTube. I have YouTube live. We sent out the links. Did you send it to? I put it on the Instagram story, and a few other individuals who reached out to me. I couldn't. I didn't see the LinkedIn on the password spreadsheet, but if I saw it, I would have posted it.
Awesome. Awesome. I'm so excited. Here we go.
Like, I don't. Everyone is. Yeah. It's still not. It's really exciting.
I want to try to catch it because 6:30 to 6:40 because we're so we wanted the last 20 minutes to be for questions and 60 minutes for 6 confirmed questions. And then if we're running a little extra on, or if we have like extra time, I have the 2 bonus questions.
Well, yeah.
Thank you. Start coughing into the microphone. Great. Okay.
I've been trying to do the topic.
It's like 6. It's also possible that the audio doesn't go here, and so if I take it to the front room. Last year was in a really weird spot. They had like a back door. Maybe it was something was in that one group that requires the back end. It's like 3.2. It could have been like the neuro. As long as it doesn't
That's how I feel.
Actually, last year, I think I applied to interview. Oh, yeah. I think you guys said that you were busy. I'm in the tunnel lab right now. Oh, cool. Yeah. Actually, the reason I applied, yeah, that's true, in the basement. The reason I applied to your lab is because I realized that you guys are special with tech devices. I think you're working on it right now. Yeah. Sleep tech.
That's right. Yeah.
Yeah, I'm actually developing a sleep tech device with my team right now. So we're doing an eye tracking software with an EEG headset. We're trying to measure sleep biomarkers on actually.
Oh yeah.
So yeah, exactly. So we're trying to find a professor who might be interested in this. Because like I was actually gonna email you guys, but I wanted to talk to you in person about this.
Sure.
We've been working on this since October of last year. We got the eye tracking device part done. We're ordering parts to build the EEG. And we're like working right now. It'd be great if you guys could help us out, you know, just like with the design process and like what we want to do is we want to get this to human testing. We want to see what sleep biomarkers you can extract with eye tracking software and an EEG. Because based on our research, like the EEG tracks different biomarkers and the EEG, putting them together, we can like get a lot more.
Yeah. That's what.
We're on the same page. We're here to learn.
Right. Yeah.
EMG as well.
EMG as well. Yeah, we combined the EEG and the EMG. We're working on the device. We're thinking about getting a final prototype done by the end of the semester. Would it be great to like meet you guys in person one time or like?
Yeah. I think Kevin's certainly come tomorrow. Are you in BME?
Yeah. I'm in the BME.
Yeah. I think maybe good. Yeah, come to Kevin's and you would talk about something, right? Because I think
Right. Yeah. Do you know when it is?
Yeah, it's next Wednesday afternoon.
I'm curious, right?
I think it's 3 hours, 7 hours.
Yeah.
Something. Yeah.
2 o'clock?
Yeah. I think. I think. Yeah.
Make it for 1 hour.
Yeah. Well, I think only the hour, but the first hour.
I mean, it's less than that.
Public, and then you maybe ask questions.
Oh, yeah, for sure. Because like we've been looking for professors who might be interested in this project. Because we wanted them to like guide us to applying for an IRB because we want to get human testing done.
Yeah.
So,
So, Longhorn Neurotech.
No. We're separate. We started this like without Longhorn Neurotech.
So just like
Independent group.
oh, interesting.
Yes.
Because I know like Longhorn Neurotech also has some groups, right?
Yeah. The thing is, Longhorn Neurotech didn't combine the EOG and EEG. We were considering to apply our project to Neurotech. We haven't done it yet. We just wanted to like validate our project with you guys and like set up a path for IRB. We just wanted to talk to you guys about it.
Yeah. Yeah, we should also like device we have right now, like the look and then yeah,
Sure, yeah, no problem. Is the lab meeting 2 p.m. on next Wednesday?
Not my lab meeting.
Dissertation.
But he will talk about that main project.
Right. Do you know where it is?
I think it's how
The seminar room with the fifth floor?
the lobby floor.
Oh, the big lobby floor? Okay, yeah. We can make it.
Yeah. You are
Yeah, I'm a sophomore. Yes.
I think it should be
Is he going for the postdoc? That's nice. Oh, that's great. Yeah, because and you guys are working on the same idea, like combining multiple devices.
Yeah, and also it's on the Yeah, it's great.
Great meeting you. Yes, of course. Lovely to meet you.
Yeah.
Is there like a way I can contact Kevin, or that I'm showing up to his thing, or do I just show up at 2 p.m.?
Yeah, I think you should show up with that is public to you. I don't know if you are on the cognitive mail list, if you are. Yeah, we also received emails about that. Yeah, you can check. Send me an email.
Sure. Yeah, I can send you an email.
Yeah. Or like Jenny's. She will be posting. Yeah.
Of course, yeah. Because I do want to attend that session.
Yeah. It should be.
Will there be like a time that I can talk to Kevin after his dissertation?
Yeah. So you come to the class and you talk to him there.
Will you be present there?
Yeah, of course.
Yes, that would be nice. Yeah, of course. So it's 2 p.m. in the BME seminar room next Wednesday. I can show up for 1 hour. That'd be great. Yeah. And that lovely meeting.
It's great to meet you.
But anyway, that's great.
Because I do a Lego in my day. So you can start whenever it's here, I probably
Well, okay, so
You guys are in Neurotech?
and I thought myself, so
I've never seen that before. Oh, yeah.
well, like you said, that's not for most people.
I don't start till the next
But
Yeah, we're working on a lot of people are signing up. Yeah, we're actually working on a no, we're not. So we started this mainly because we're gonna apply I know a lot of people can actually show it to you. The thing is that our project is like highly speculative right now. We don't have like an instrumentation for design process. We're trying to put sensory information with pans.
Dr. How many minutes?
I know exactly what we're doing right
Let's
now.
wait until it comes.
Can I just say we're talking like
Yeah. So we're waiting on one more minute.
Sometimes I forget the experiences.
Hello? Hi guys, we're gonna be talking for another 5 or 10 minutes as we're waiting for Dr. Amadio. He's gonna be here soon. He's parking right now and then he'll be coming. So whenever he's here, we'll all be ready and you guys feel free to chat for a little bit longer, but we'll round up in about 5 to 10 minutes.
yeah.
Yay.
Anyway,
Yeah, so the feeling.
yeah, the thing is,
I'm really excited to just walk. I got some
neuralization German, where
I'll leave that. We actually
The beauty of amputees is even though the rest of the body doesn't grow, what we researched is that the nerves continue to grow. And what it formed, obviously they can't, there's no arms. So they like twirl up into a ball. And the thing is, each nerve ending fully grows up to the fingers and all that grows back, just crumbles up into a ball. They will depreciate it over time. So what like a current surgery that exists right now is that they unravel that ball and reattach it to the distant skin. Left over. It's a very we're gonna put electrodes. Yeah, exactly. The surgery itself is extremely, it's not in the research stage, it can be done, it's been done. But it's rare enough that you need like a high specialist. And the only reason it's rare is that it's just not popular. I don't, nobody sees the point of like re-innervating every neuron. But until now, if there's an effective way that we can signal information back to the re-innervated neurons, you got what you want. You got feeling and pain. So that's exactly what we're working on.
Everything feels all of the sensors that have some so we can right, maybe it's not some way that some neurons basically whatever
I won't break up.
Right now we're just trying to see how can we mathematically represent how the hand reacts to the stimuli. We're using mechanics using reactive forces from the stimulus, and we're converting those reactive forces into like quantitative values that we can then input into signal. That's the pipeline of this project. That's why we don't have an instrumentation center. We're not instrumenting anything. We need to prove that this model works. We're addressing like a bunch of issues.
But it's interesting, Mario.
Yeah. Don't try to get
I feel like you got a lot of perspective, especially back.
I know like his big thing is he's a neurosurgeon. Honestly,
Everyone's just gonna get
I just need to know if he knows everything. It's just a start. The thing is, we're treating the brain like a brain. The idea is that we just need to understand the signaling the brain responds to, the signaling the brain sends back. We're starting with that. Alright, yeah. That's basically we're starting regionally and if we can effectively send signals for the rest of the human body, there's obviously some discrepancies with binary research. The only way we researched it, because this actually has been done, but with human touch, they stopped it midway because they didn't get paid. They're not able to effectively move The thing is, if we said we did with TSR surgery, which is we isolate specific nerve regions, like large enough regions where if we send signaling in a specific specific way activate one fiber protein. This has been yeah, outside of neurotech and now we're talking about we're working on a prosthetic device that can brain sensory.
Alrighty, you guys, start making your way back towards the crowd if you guys are asking questions. Welcome
Right
back to
now, we're just
volume.
researching medically because we need to and then once we have a concrete understanding,
Okay, Raquel. This is still running. Hi guys. The forum is starting now.
see if
Okay, we can start. Yeah. So when you're speaking, would you want to click for the smooth flow? Because personally, I want to click. Okay, so forward, backward, laser. Doesn't work. Don't even bother. Yes.
Alrighty, you guys, if we could all make our way back to the seats, and then we'll let the speakers take their seats. We'll have time to chat a little bit after as well, but if for now, we could all take a seat and then let our panelists sit after the front. Hello, everyone. Thank you. Can you all hear me well? Well, thank you so much for coming this evening. My name is Raquel. I'm the president of Longhorn Neurotech, and I'm very excited to welcome y'all to our second annual Future of Neuroengineering Forum. We have the privilege of being in front of all these panelists today and getting a lot of their perspectives on where the future of neuroengineering is going and how we now play a role in that. So I want to just start by introducing your Netta and Donovan.
Hi, I'm Netta in Neurotech. I'm the VP of Education, and I'm a neuroscience major.
Hi, everybody. My name is Donovan. I'm a sophomore biomedical engineering major, and I run Signals and Journal Club in Longhorn Neurotech.
Awesome. As some of you might know, Longhorn Neurotech is one of the largest neurotechnology organizations in the entire country, and it is the one and only neurotech organization in UT. And we get to be privileged enough to be a part of a community where we want to combine neuroscience and engineering and see where that might be going and how that might impact the world of medicine. So I just want to mention that today we hope to see how opinions and perspectives have grown throughout the last year. We hosted this about a year ago exactly. And so there's been a lot of changes in our community since then. So we want to see what changes have occurred and how that might impact the world of neuroengineering as we know it. And I also want to mention that we want to bring public awareness to the growing horizons of the field. And we aim to bridge the gap between the complex research and how that might impact society. So please welcome our panelists. I'm going to go ahead and introduce each and every one of them. Starting off with Dr. Jared Louis-Kukoff, associate professor of psychology at UT Austin. He holds degrees in electrical engineering, computer science, and psychology from the University of Wisconsin-Madison, and completed a fellowship at Princeton. His work focuses on the intersection of cognitive control and memory using real-time neuroimaging to decode how the human brain supports goal-directed behavior. Next up is Dr. Jordan Amadillo, a board-certified neurosurgeon and affiliated faculty with Texas Robotics. He received his medical education from Harvard and MIT, followed by an MBA from Harvard Business School. In addition to his role as a director of neurosurgery at Neuralink, his work focuses on the intersection of neurosurgery and innovation, specifically developing next-generation robotic tools and implants for the spine. Next up, please welcome Dr. Evan Wang, Assistant Professor of Biomedical Engineering at UT Austin. Dr. Wang earned his BS from Oxford and his PhD and postdoctoral training at Stanford University. A recipient of the NSF Career and NIH Neuro Awards, his research focuses on functional nanomaterials and genetic technologies, creating minimally invasive tools to record and modulate neural activity. Next, please welcome Dr. Samantha Santa Cruz, Assistant Professor of Biomedical Engineering at UT Austin. Dr. Santa Cruz holds an applied mathematics degree from UC Berkeley and earned her master's and PhD in electrical and computer engineering from Rice University. An NSF Career Award winner, her research focuses on systems-based neurotherapies, merging data-driven modeling with neural interface technologies to treat neurological disorders. Please welcome Dr. Jose Del Arminan, Professor of Neurology at Del Med and the Carol Cockrell Perron Chair in Engineering at UT Austin. He earned his PhD in Computer Science from the Technical University of Catalonia and previously held the Dyfresh Foundation Chair at EPFL in Switzerland. An IEEE Fellow and Norbert Weiner Award recipient, his work focuses on pioneering brain-machine interfaces, specializing using EEG signals to advance the field of neuroprosthetics. Finally, please welcome Dr. Francisco Gonzalez Lima, Professor of Psychology, Pharmacology, and Toxicology at UT Austin. He earned his doctorate in Anatomy and Neurobiology from the University of Puerto Rico and completed postdoctoral training in Germany as a Humboldt Fellow. With over 350 publications, his research focuses on non-invasive brain stimulation using infrared laser technology and multimodal imaging to enhance cognitive health. Thank you all for being here, and I'm going to go ahead and pass this on to Netta and Don.
Sounds good. Okay, we're going to start our interview section of our discussion, and then we'll have an audience-based question. All right, so to begin our discussion, we want to start with the big picture of where neural engineering is headed clinically. So across the panel, we're seeing rapid progress towards technologies that don't just record brain activity, but interpret and modulate it in real time. From EEG electroencephalography, which uses soft electrodes to measure electrical brain activity based, to brain-machine interfaces, to adaptive neuromodulation, and more. Which recent advances do you see as most likely to restore lost neurological function in the near term?
Thank you for having us here. And this is one of the questions that I can address. Right now, I'm in the phase of trying to move some of our work into clinical applications. And the particular technique that I use is a neuromodulation technique, but it's very different from the other ones that you probably have heard about, electrical or magnetic stimulation, nowadays also ultrasound. The technique that I use is something that was primarily developed here at UT Austin over the years, first in animal studies, then translated to humans. And it uses light, primarily near-infrared light, to get into the forehead, reach the cerebral cortex, and be absorbed by mitochondria, that normally they have electron donors, or the photons act as electron donors. With this process that's called the photoelectric emission effect, we can facilitate electrons moving to oxygen, generating more energy in the form of ATP. So when you do this, you can improve all kinds of prefrontal functions like cognitive and emotional functions. But it also has neuroprotective effects because now the brain has more resources. And there are now laser devices and LED devices that can be used non-invasively in different populations in collaboration with Delmed colleagues. We're doing this in depression, bipolar disorder, and ADHD, and our most recent studies in autism. And if you know people who have these conditions, they're welcome to contact me.
You were saying naming the series of components, and I think that the only way to move forward and to reach our goals is to identify which is the proper combination of all of them personalized for every individual. Did you hear me?
Maybe a
You
little
need
bit.
to, okay. So I will repeat short version. You need everything.
Yeah, I agree. I think that I work in the more invasive side of things, and I think sometimes it feels like there's a conflict between the non-invasive or minimally invasive options and the invasive options. But I think we really need a suite of tools because I think it's very kind of patient-specific, disease-specific. Like I think when you go to the doctor, you probably don't want there to be only one choice for what's going on with you, right? Depending on what stage you are in your given condition, whatever. I think you want multiple options. So I think we need all of these things to be evolving towards the future. I think the other thing I would say is that I don't think for everything it's about restoring neurological function, but perhaps can we replace neurological function? I think in some instances, some of the technologies, that's the goal. Is that we don't know how to restore it, but we can replace it with our BCIs or machines.
Yes, my lab was focused on neuromodulations, and so I basically then maybe give you some introductions about this field, especially at the clinic. So a field technology in clinic, including using electrode for deep brain stimulation for treating Parkinson's, and then if you are looking at more non-invasive, like a cortical stimulation, including like TMS or transcranial electrical stimulation that are used for like treating depression related. And then I guess a more like emerging technology, which my lab is also working would be using ultrasound that can also reach deep. So TMS or like electrical, those mainly stimulate the cortex. They don't have very good like spatial resolutions. Ultrasound technology which can also penetrate deep in the brain and also have a much better spatial resolution, so you can stimulate deep in the brain and probably not as high spatial resolution as electrode, the DBS, but it's certainly much better in comparison to other non-invasive methods for neuromodulations. And my lab particularly is also moving this technology to be like in a wearable format, so trying to do like a long-term, because the stimulation is not like once you can solve the disease, many like deep brain stimulation for Parkinson, it requires like a long-term treatments. So basically, my lab are also solving the issues like making the device to be like miniaturized and make the gels to be like a long-term stable, so we can basically do like a variable neuromodulation over time.
So Jordan Amadeo, thank you for having me. This is really exciting. I think Professor Zachary said it really well. There's going to be a suite of technologies and solutions that are going to be each designed at attacking a particular part of this overarching problem of neurological disorders and disabilities. Non-invasive solutions, very interesting, very exciting. Invasive solutions, which is more of my work. Also very exciting and interesting for different applications. I think ultimately there are applications which we can get into for which non-invasive technologies will not be sufficient. And you'll need to go invasive. At the same time, there's areas where you would not want to go invasive, right? I think probably most of us in this room would rather try out something non-invasive than invasive. So I think all of this work is first of all, we're in the early innings of this as a human species, right? We're now in a time where it's just full of possibilities. And so all this work will be playing a major role in our lives in the years to come. I come at this as a clinician. So there's a lot of world-class researchers here on the stage. I'm a clinician. I'm not only involved in developing technologies, but in seeing patients. And I came at this initially from trying to help my patients. They're real men and women who have real problems that need help with technology. And so, for example, spine surgery as a neurosurgeon, one of the things we do, which is not closely related to our topic tonight, is spine surgery. And I've taken care of hundreds of people with spinal cord injuries. I've operated on them. And despite our best efforts, they're still severely impaired, paralyzed or very close to it. I want to be able to do something to help those people using neurotechnology. And so fundamentally, whether it's a non-invasive solution or invasive solution like the ones we're doing at Neuralink, these people need help. And I think it's really on us to help produce those innovations. That's the perspective I have.
I want to thank the organizers for putting this on and inviting me here, and I want to complain to the organizers for putting me after Jordan. How do you follow somebody who has done 100 spinal cord surgeries and speaks so eloquently? Here comes my spiel. I work in the non-invasive realm. I'm a basic science researcher whose goal is to better understand the neural code underlying various forms of cognition and cognitive control. What I immediately was thinking about from the question of what recent advance sticks in your mind, was exciting or promising development, Dr. Wang already hit on, which is the use of TMS stimulation to treat otherwise non-responsive major depression. And there's been great successes in that application. When you think about this, TMS is it's non-invasive, it's great, it's a very blunt instrument. Putting a magnet on someone's head and inducing some electricity underneath the skull, and it's improving their psychological condition. Fantastic. But wow, is that ever a blunt instrument compared to the very fine-grained way that our brain holds, processes, manipulates information. And so what I'm excited about is taking that kind of non-invasive translation of research and making it individualized, specialized, and much more fine-grained, so that we can provide clinicians the option and opportunity to treat patients by not just by raising and lowering the temperature of a particular brain area, and there's much value in that, I'm not discarding this, but rather by training their brain to instantiate certain states that are more adaptive, that can lead them back to recovery or health. So it's kind of precision medicine applications of the basic science, cognitive neuroscience work that excites me.
Thank you guys for talking about all the novel technologies that are super exciting, that are being developed, both non-invasive and invasive, which moves us really directly into the next question about how these technologies can move from labs into hospitals and how they actually fit into clinical care. So as neurotechnologies become more common in clinical settings, clinicians' attitudes towards them are starting to change. Some are excited about how these tools could fit into everyday practice, but others still remain cautious. For many physicians, concerns about reliability, workflow integration, and patient trust can play a big role in whether they're willing to adopt these technologies. From an engineering perspective, should development focus on tools that support physicians in decision-making and surgeries, or on highly automated systems that are designed to operate with minimal physician interaction? How should engineers balance designing for clinical usability with pursuing more autonomous technologies like robotic implantation platforms that are used for devices like Neuralink?
Yeah, I mean, that's a tricky one for me, right? Because I'm a surgeon, so I like to think we're going to play a role. But at the same time, we are automating a great deal of the process. We're not there yet, to be clear. I mean, so speaking specifically about Neuralink now, where I'm one of the 2 people on the planet that has implanted these Neuralink devices. We've done 21 humans so far, and counting. And hopefully this year will be a much larger number. Those have all involved like surgeons like me going in and creating automated, bringing in the robot, and the robot then inserts these tiny threads into the cortex. So it's a human-robot collaboration, and it's actually in many ways similar to some of the work we're doing here at UT in Texas Robotics, where we're finding ways of creating surgeon-robot collaboration. It's not that the robot replaces the surgeon; it's that the surgeon is made a better surgeon, a more precise, accurate, reliable surgeon with the use of robotics. So I don't think it's either or. In the special case of Neuralink, we are, as a company, trying to automate basically everything. I think it's going to take a little while to get there, but it's a procedure that's very closely constrained. So in robotics, robots do really well when something is very closely constrained as a procedure with minimal variation. That's kind of what we're doing. It doesn't apply to surgery or neurotechnology necessarily as a whole. So I think it's a complicated answer, but I'm a big fan of robotics. I think robotics are definitely the future. But for now, the input of physicians is important. And this wasn't maybe exactly your question, but clinicians as a whole, I would say, are eager to adopt things that are proven to help patients. Ultimately, right? Maybe that some are more forward-thinking than others. But the proof's in the pudding, right? If something is so incredibly helpful for somebody and works really, really well, I don't know many clinicians that wouldn't want that for that person. And so, yeah, we're starting to see that change in Neuralink. People that are not procedure oriented, in medical specialties like neurologists and rehabilitation specialists. This is a bit of a generalization, but often people from those specialties have been less excited about implantable neurological devices than neurosurgeons, who are all about it, right? This came up with DBS, right? When DBS came out in the 1990s, neurologists were initially reluctant to refer patients for brain surgery because that was very scary. Then when the data came out from many randomized controlled studies showing just the incredible benefit for example, Parkinson's disease, that has now changed completely. There's now a conversation in psychiatry going on about psychiatrists referring patients for implantable neural devices, which also a lot of reluctance in that field. But I would say, Evan, maybe things are coming around, right? So it's a great question.
I heard something cool recently, so I can't, not cool, but I think is a good response to this. I can't take credit for it. I heard it in a conference. But they said if you design something life-saving, but people don't use it or they can't use it, then it's not life-saving. And I think that really hit me, right? Like you can design the coolest thing, but if it's not being adopted for whatever reason, then it's as if you didn't even make it, right? So I think thinking about the user's experience, where the user in this case would be the surgeon or another clinician if it's not a surgical thing. I think that's very important. But I think the question that should be driving all of us is really what's best for the patient, not necessarily like what's easiest for a physician or clinician to adopt and to use and optimizing it for decision making. I think everybody from the people working at the bench doing basic science to the engineers making a physical device or something, and then the doctors that are implementing this with patients, I think we all have that same goal of what's best for the patients. So I think that's driving things more than if it's just easier to use.
I would like to add that yes, it is right that something that doesn't bring the benefit, there is no reason why you should be adopted. And in fact, this is one of the criteria that FDA has to approve any medication or intervention. I think that the field of neurotechnology at large and BCIs specifically has proven many times that when it comes to the field of neurorehabilitation, the improvements, the gains in functional recovery are above many other interventions actually. It is the only intervention that is working for people who are so severely disabled that they don't have any other option and they are simply abandoned by normal clinical processes. But this doesn't mean that this has all the path already ready to be adopted. There are other criteria. One of them is how easy it is to use. Can clinicians use it independently of the evening development? And I think that this is already partially the case. We have been designing BCI protocols where clinicians, we train the clinicians and they will run independently, and the results are there. But yet, this is not sufficient, because in order for a patient to benefit from any kind of intervention, someone has to pay. And who is that someone? Is the insurances. And this is another battle. So I hope that with the new hospital that we are about to have here at UP, this process is not walked in the way that normally it is done, where first you make the invention, then you test it in a few subjects, then you scale it up, and then you realize that, oh, this seems to be working, let's make it simpler. And then finally you go to get the approval. No, everything has to be designed since the very beginning at once to accelerate the time to solution. And this is where UP and the new hospital, and when I say UP, I'm talking about the whole UP, not just these school or that school, can be the revolution for the
Totally, I also agree with speakers. So I guess really will depend on the doctor's opinion, patient's opinion, also insurance. So those, I think there's also, if you want to look at like what determines the technology can be utilized in a clinic, I think there's also, I recommend to also look at the Stanford Bio Design textbook or lectures. So where I attended a lot during my time at Stanford, so that those processes really determines like if the something can be really utilized. So for example, I also want to emphasize a little bit more about the insurance, for example, or wearable ultrasound, right? So what I'm currently also talking to is like what kind of like a reimbursement code can be used for the for like a surgical, like there's certainly like a really good like a insurance models, right? But for the wearables, they don't generally a pretty cheap insurance code for those wearables. Then we need to think about if this makes sense, right? To go to the to have a product, right? So wearables, although it's like non-invasive, looks cool, but then what would be the how much you can get the reimbursement for that? So I guess certainly it would be the same with robotics, right? So that's very new areas, right? Then would the doctors be happy to use, or would the patients be beneficial, and then the reimbursement have the right code to pay for those? I think those would really determine if the technology can be used in the clinic from the lab.
Let me add a different viewpoint. One in favor of autonomous systems. There are a number of conditions that may be amenable for that. For example, we in a recent paper that was published this year show using internet-based cognitive behavioral therapy. In this case, you're replacing something that clinical pathologists, psychiatrists do with an intelligence system that they use in their own form. But what is even better than that? I am a little biased here because my two sons work on robotics. They're engineers, and they're always asking me these questions. So, certain conditions could, for example, some of the devices that we use in the lab now, you can put these things on your head. They will be able to monitor the activity in, for example, your prefrontal cortex. And you can also talk to the device, like in the case of this cognitive behavioral therapy, and tell what's the problem, what is it that you are concerned about. They're going to monitor your activity. For example, we know that in cases where the people have problems with depression, there is less activity of that prefrontal cortex that is managing at least the more anterior regions. So the device can make a decision, well, let's stimulate the same device that is monitoring that. For example, in the case of our lasers or LEDs, they can start providing near-infrared energy that is going to be absorbed by that prefrontal tissue. The mitochondria is the primary photoreceptor. More energy is going to be delivered, and the AI will be directing how to use those energies in a positive way. For example, in that study that I mentioned, when the people start improving in response to this internet-based cognitive behavioral therapy, then you provide the additional energy to the prefrontal cortex, and then they improve over 40% over those that only get the psychological treatment. So this is a case of really autonomous systems that could be implemented, and it is completely safe from the point of view of that light is not going to be damaged. And it is important then that that light is delivered when you're ready to benefit from it. That is when you're showing improvement. Because many people, for example, when they mention the transcranial magnetic stimulation, what it's doing for depression is primarily disrupting that process. Because in depression you have rumination of negative thoughts and emotions, but there are psychological techniques that can overcome those ruminations and you start looking into a more positive outcome. And now you can reinforce them synergistically with something like this. It is possible also to add electrical stimulation like a DC current at a very low level, transcranial current stimulation, that to be done also in a fairly autonomous manner without risk. However, I'm not talking about assisting a neurosurgeon doing a deep brain stimulation during the goal here, but making patients now empowering them to be able to access this technology whenever they need it. You know, they're in a crisis, they go there to their autonomous application, they put it on top of their head, and they start with an interaction that is going to address that crisis right there. How long do I have to wait to see a neurologist or a psychiatrist here in Austin? 2 months, 1 month, even in the case of a crisis. So these things can be done, and the AI is reaching levels that they can simulate really well. Some of these therapeutic approaches is because they follow certain rules, and you're constantly giving feedback, just like a machine learning approach. So I am in favor of certain types of phenomena, especially in the first slide that is all about sustained attention, cognitive enhancement, memory augmentation, cognitive flexibility, emotional regulation, all of those we could do with these kinds of robotic autonomous systems.
Awesome, very insightful. So real quick, before we move on to the next question, can I go from left to right, double mic tap, and then we'll do any switch outs if necessary. So
We'll just go.
this way. Now you do it tap tap. Good. Okay.
Okay.
Next
year, you might get 2, 3, and 6.
Now's a good time if you can't hear in the back. Now's a good time to move
All
down a little.
Mics 2, 3, and 5 move up on those.
Okay. Silently.
Yes.
Okay. Is there some from here that we can
Answer
grab?
is on.
Okay.
Yeah, 2, 3, and 5.
2, 3, and 5.
Thank you, guys.
Yeah, it should be all the way max.
Yes, no.
Yes, yeah.
And then 1 and 2 are too loud.
Or 1 and 2 are too loud.
They can go up.
Did go up.
They can go up.
Yeah.
They're all at max.
The rightmost master volume.
Yeah, like.
All right, you guys. So people in the back, if you guys could just move up a little bit, and we'll start on the next question.
Yeah, guys, come on. There's room. Go for it.
No tech solution.
Okay, perfect. Yes, exactly. Yes. Yes. All right. Thank you for this holistic perspective on both human side and machine side.
I have something I want to add to that last
Yes,
question.
yes,
If
please.
I won't filibuster here. So how many in the audience right now are using AI chatbots to help you with your homework or your research? Okay, I think that's about 100% hit rate nearly. And so I probably say that I am, and using AI tools are making me a better researcher, where I have a always available, never tired research assistant to help refine my thinking, to help me do better discovery of existing research. And I think these tools are just going to get better and better. And the goal is to integrate them into what we are doing, not as a replacement for what humans uniquely do. So I'm all for using them to help study students and for us faculty folks to do the work that we do. I'm curious about, and I'll throw it to Jordan, about how AI tools could be used to assist, augment decision-making processes in high-stakes critical environments in surgeries and so on, where you already made the relevant and understandable point of like self-preservation or job security. Like, I want surgeons to be needed, right? And you have to go through intense training to be able to do what you do. But what if there are tools that are developing that can ride alongside you in what you're doing and be assistants that can help you make faster, more efficient, more effective decisions? Is there a resistance to that in your field? What do you think about that?
I don't think so. I think that's a very promising area, and there's already examples of technology that might be a little bit short of what we would consider AI, that is computationally enhanced technology that have been part of what we do day in, day out for a decade now. Computerized navigation, for example, is like I won't do a surgery without it in certain circumstances. So it's really made all surgeons safer, I think, and allows us to do things that are more precise. Talk about smaller incisions, that sort of thing, but really just safer and more accurate. In terms of AI, I think there's really cautious optimism in the world of medicine and surgery in general. I think from a just a clinical standpoint, you have to be careful of hallucinations with LLMs, and there's a platform some of you may have heard of called Open Evidence, which basically fixes that. It's essentially kind of a multiplex retrieval augmented generation tool that's trained on the publicly available medical literature, and it's incredibly good. It's essentially it's like having a medical school distinguished professor in your pocket, probably better than the distinguished professor. So for things that are decisions in medicine, you have really good tools. And I refer to it all the time. If I want to know, what does the latest literature guidelines say about about a 3.8 centimeter brain tumor of this region that's been partially resected. What's the appropriate radiation protocol? Something like that, for example. those tools are incredible. In terms of within surgery, I think we're getting there. There are examples that are starting to occur. Autonomous robotics is tricky. Dr. Milan knows, in the OR, the FDA makes it really hard to get something over the line if you call it autonomous. So human in the loop is going to be very important for the foreseeable future in medicine, which is probably a good thing. There are some kind of warning examples. I think it's J&J now that is facing a major class action lawsuit related to one of the AI technologies that came out a few years ago for ENT navigation, for basically sinus surgery, and they had essentially an AI aspect of that would tell the surgeon, you're in this sinus versus that sinus versus too deep, you're in the brain. And some people got into trouble using that, and there's now there's patients that died and so forth. So there's now a class action lawsuit that is putting a little bit of a freeze on some of the AI technologies in surgery. But long term, yeah, for sure, absolutely. It'll be part of everything we do, including surgery.
Yeah, so this type of autonomous loop is exactly what our next question is about, where many medical devices that interact with the brain today, as you said, Dr. Mario, operate in an open loop way. They deliver stimulation continuously using preset settings that are determined by a physician. But researchers, like Dr. Sandra Cruz, are now developing closed loop systems, which can monitor brain activity and automatically adjust stimulation in real time based on what the brain is doing. These adaptive systems are starting to show promise in conditions like Parkinson's and could eventually be used in sensory prosthetics that help people see or feel again. So this raises an important question. Will fully autonomous closed-loop devices become the new standard, or will we move towards a hybrid model where open-loop and closed-loop systems are used selectively depending on the patient, disease stage, and available resources? Okay. So I guess if we're thinking about like stimulation-based devices, there are a couple options out there which are almost closed loop. So there are like responsive stimulation devices. So for example, Neuroprosthetics is a company that does stimulation for epilepsy treatments. They have a device that tracks neural activity and will trigger stimulation when it detects that there's going to be a seizure on site. And it'll deliver stimulation for some period of time, and then it'll turn off. And it'll continuously operate in this way autonomously. So things like this exist. I think closed loop deep brain stimulation has been talked about for quite a long time now. And I think it still has yet to be solved. But I think we're getting more comfortable with the idea of maybe it's not for everything. I don't know if people would agree, but I feel like in conferences that I'm going to, that there's like a little bit less enthusiasm. And I think in part because open loop does fantastic in a lot of cases, right? It can be fantastic in a lot of cases. So yeah, I think the ideal closed loop, if you can do it, is great. I think also if you're truly doing closed loop where it's adapting parameters based on need, if open loop is optimal, then the closed loop controller would converge, right? So in that sense, like, I don't know if that would be considered a hybrid approach, but if we truly solved closed loop and open loop was good in all the cases, we should get there too. But yeah, I think we're always going to need systems that should be adjusted, right? Especially for degenerative conditions and where the disease state is changing, that therapy needs to change, right? So whether it's human in the loop adjusting parameters, which is how we do DBS now, right? There is a clinician in the loop that adjusts parameters as disease progresses, or if it's fully autonomous. I think again, it's really kind of disease specific. I think some of the things that I'm most excited about for closed loop DBS is for non-degenerative conditions. So, electrical stimulation and neuromodulation therapies are being investigated now for so many conditions. So I'm thinking in particular for like psychiatric applications where There's not necessarily degeneration or like a lesion or something that's happened, but there is a pathology there. I think there's a possibility of something like closed loop, figuring out how to drive the brain to essentially unlearn this condition that it's in. And I think the dream for me in that case would be to come up with a neuromodulatory treatment that, if it's invasive, could ultimately be explanted, right? To create something that was curative. And I can only see closed loop getting us there, not open loop. But yeah, I think it's like most things we've talked about, like it very much depends on the problem you're trying to solve.
Well, I think that theoretically there is an advantage for closed loop, because the point is that not every single stimulation pattern will have the same effect. That will depend on how the brain is at that moment. And this is what closed loop is about. That identifying which is the state and delivering the stimulation only when it is in a pathological condition. Now, the question behind closed loop is, which is the marker that should trigger? In the case of the epileptic seizures, well, there are decades of research that is indicating that there are very clear spikes and other things that are indicative that is the marker. In the case of TBS, in the very beginning, people were talking about abnormally high beta rhythms. And there were studies that were showing that indeed with closed loop DBS triggered by these abnormally high beta, people were having similar effects in sense of beneficial effects with way less electrical current being delivered. And we know that the more electrical current you are delivering in the brain, especially in those areas of the brain, more side effects will be produced. So it works very well. We carried those experiments until we realized that, hey, beta is a natural marker of behavior. And you are expecting beta to go high whenever you are transitioning from one state to another. And then, when we design experiments where patients with DBS controlling closed loop were doing tasks transitioning, their performance decreased. Because you were targeting a marker that in many cases is pathological, but there are cases where it is natural. So this is for me the major, challenge of closed loop. Which is the marker? Are we sure that this is a marker that is always beneficial no matter what? How these markers will be evolving with time? Because ideally, the fact that we are doing a neurotechnological intervention should induce plasticity. Do we understand those plasticity processes? No, I don't think so. But this is not telling you guys, forget about this. No, this is telling you, hey, you will be solving the problem. Because there are so many things that we don't understand yet that you will be making the discovery that will pave the way for these neurotechnologies to advance.
Yeah, also keep mentioning like, so the closed loop there, I guess two type of closed loop, right? One is like a basically responsive, like when you have the symptoms, like we have a higher amygdala activity, good stimulation to suppress anxiety and seizure, like neuropathy, you stop. And then there's another type of just to record the signals and to not like a responsive, just to look at if you stimulation at the right place or like have the correct effects, and then monitoring the disease, right? I think certainly I think there's more and more like a device you can see like currently like a Medtronic, the DBS, they also incorporate the recording functions. There's also like the pain, like the Saluda, the company doing the spiral cord neuromodulation. They also add in the recording to verify they can successfully doing the neuromodulation for pain, and then I think certainly I think has importance. There's a growing interest on the at least you monitoring the you are doing the correct stimulation. You are probably like you are reducing the symptoms and or like you get the correct activity modulations. But then for the responsive one, then how if it is going to be used, it will really depend on the therapeutic effect or like how convenient or the cost of having that part. But I think I would just think it's totally mainly the therapeutic effect will determine. I think it certainly helps sometimes like to saving batteries or like saving like we only doing the simulation at a short period of time. But I think overall, I think there's something like increasing interest in at least monitoring the neuromodulations.
Awesome, thank you so much. As we pivot from looking at closed loop devices in the OR, I think we should switch places and move to the courtroom and consider some legislation that could potentially like affect the direction that BCI is going, as well as protecting the user. Which is why we thought it was important that we take a look at BCIs, and as they become more advanced, they can like contain more advanced data beyond just brain signals, and contain things like our thoughts, memories, etc. And so, should this brain data be recognized as a new human right? And who is responsible when this data starts being collected, sold, or even potentially subpoenaed in court cases?
I can say that there are already this kind of regulations. The country Chile has in the constitution the right to protect individual brain data. So this is not new, and there are here in the US groups that are discussing how to create the legislation to protect that data. And on the other side, we are talking about data. So we don't need to reinvent the rules. There are already data protection rules that we need to be aware of. So what to leave the people, especially when it comes to understand your future behavior, that gives room to manipulation, and whenever you are using your electronic devices, you are bombarded with this kind of incentives that are specialized, that are targeting your behavior in those electronic devices.
I'd like to follow up with that with the not brain data itself. But for example, when I was referring to the internet-based cognitive behavioral therapy, you're providing data about yourself. One of the major problems that we face using that was our own IRB here UP, because the device is in the internet. So there is a potential that some bad actors can try to get in there and learn about vulnerabilities of individuals. So this was a really difficult thing to deal. and all kinds of reassurances from this was a German company who made this to show that there was state-of-the-art protection for that kind of data. That is more, perhaps it's more easily translatable for a bad actor than brain data. And we are experiencing already these kind of regulatory issues, and sometimes, unfortunately, the default of committees who are not aware of the regulations or that they don't want to assume responsibility for their tasks, like an institutional review committee is supposed to assume responsibility for the safety of the projects. They are just shifting this by default and just rejecting. There's a possibility of something wrong in terms of the data protection, so no. And unfortunately, some of this is also happening at the federal level. The FDA is assuming when you send something to the FDA nowadays, it ends up usually in the hands of pharmacists. Sorry if there's a pharmacist, no, also doing appointment in pharmacy. But a pharmacist is a very full expert to talk about these kinds of phenomena that we're talking about here. They're more traditional in terms of medication, and even when you're talking about investigational new devices, approvals, you have these kinds of people that are making the decision. And it's, from my own experience, I think in 2013, I moved from animals to humans. It's not an educated group of regulators out there. So our community, our scientific and medical community, they're going to have to do a lot of effort. It is good to have regulation. The problem now is that they don't want to assume responsibility, and therefore the default is just to put a roadblock and let these things happen. We are constantly bombarded. I visited recently Institute for Human and Machine Cognition in Florida, and they have this incredible monitoring of all the cyber attacks happening to our internet system here in the US. This big screen, it is a constant project. And in fact, they're using AI to cancel attacks. And if I may say, the Russians and the Chinese, who are the primary players, minor North Korea, Iran, hopefully Iran not anymore, they are doing this, also using AI as well, in addition to personnel. So this is not going to go away. This is going to be a constant risk, and there's just no way other than try to mitigate it with counter-offensive that are being developed. And but I really would like your generation to be willing to take this risk. Otherwise, if we don't take this risk, there's not going to be any advancement. If you want to play it safe, the best thing that the IRB is very happy is if you don't do anything. But as soon as you want to do something, then there are risks involved. And of course, some of my colleagues here, like the surgeons, every day when they go to that operating room, they are in an environment where with lots of risks, and many of them unpredictable. So we need to be able to accept this and face this. We are, after all, in Texas, the frontier land. What starts here changes the world. So we are hoping that you're going to be able to do that for us.
Awesome. Thank you so much.
Can I add one thing?
Yes, absolutely.
I just wanted to say that the neural data is already being sold. This is not like, this is in the future, we should figure it out now. So Rafa Yusta is one of the people that I think Jose was referring to as part of organizations that are trying to establish neural rights. I was talking to him recently. He said that their organization read through the fine print, like what you scroll through before you pick the box and select OK. So they did this for like 28 wearable companies to record neural data. And 27 of the 28 have it established there that you're agreeing that they can sell your data to third parties. So if you've ever used any sort of like, headphones that are recording EEG or put on any sort of cap, anything like that, your data has been sold, right? So that's already, I think, happening. Yeah, so I'm not so worried about them being able to decode my thoughts because I try and do that every day in my research, and it's basically impossible outside of context. And it's nowhere close to just getting access to the AI that I talk to, right? Like AI knows us all already. They know exactly what you're doing. Much easier to just ask like AI that I talk to what is going on with me and how to manipulate me than to try and figure that out for my neural data. I think the real concern to me with neural rights is with regards to insurance getting access to neural data. So for example, a diagnostic for if you have epilepsy is looking at your neural data and looking for that seizure activity. If somebody has not disclosed to their insurance that they have this condition, then insurances may be interested in buying neural data specifically to disqualify people from being reimbursed or not insuring them. I think there's things like that that are more concerning to me than just like them being able to know my favorite color is purple.
Let's say a couple things. Yeah, I think this clearly needs to be figured out, right? And there are people already working on this. If you think about it in terms of what this reduces to, fundamentally the neural data that we're worried about might be, for example, if you're decoding intentions or decoding intentions on keystrokes or keyboard strokes, typing something out, right? Or maybe speech intentions from a speech BCI, for example, right? Yeah, those are real. I think anyone can kind of grasp that that's not science fiction. It's like if you understand what I'm typing to somebody else or what I'm doing with my computer, that's like private, right? I don't want people to have that. So I think it's important, but at the same time, that does kind of reduce the problem of data privacy in general, right? I don't think it's a special case. It's just a special application of data privacy in general. I think Samantha said, your LLM, your AI account, if your company probably knows you better than anybody else, probably knows you better than your brother, your sister, your spouse, right? So it's pretty scary, right? You want someone to get that data access. So yeah, this is important, but at the same time, I don't think that we should allow this to derail progress, and that we need to strike a balance. In the university IRB setting, that's one thing. In the commercialization setting, we will have companies that are involved in this loop, just because there's AI and inference in BCI technology, right? For example, the things that we're working on are implantable, completely wireless technologies that have very limited compute power on the edge, right? So all that inference is going on to decode the neural data and figure out what the heck we do with these signals. That's not occurring on the edge. That's occurring, in the cloud and in a centralized fashion in most cases. So until that technology becomes radically better, which I think is probably going to be a very, very long time, and will probably be outpaced by increased complexity needs of the actual devices themselves, there's going to be a centralized authority involved. There's going to be a company that's providing the service that's going to have your neural data, and so we need to keep those entities in the loop on this, whatever regulation comes about. I don't think the future of decentralized BCI, certainly for high bandwidth interportal applications, is very likely in the near future.
Awesome, thank you so much. And yeah, it is crazy how neural data is already being sold. But as we were talking about epilepsy and the brain signals and how, many BCIs were used for therapy usage, rather as device control with those with ALS or epilepsy control, it is important that we take a look about how people are considering further advancing their cognitive abilities and like advancing their abilities as humans. So that's why for our question 6, we decided to consider, like, as BCIs move beyond therapeutic use, like what are the most compelling and realistic benefits for healthy individuals choosing to adopt neural implants? And what does that shift signal about where the technology is headed?
So I'd like to mention briefly the technologies, these non-invasive technologies like the one using the military lasers or lights, they have been primarily tested in healthy people. In fact, our students from UT Austin, I think we have over 2,000 of participants from campus that have undergone this to improve sustained attention, improve learning, memory retrieval, cognitive flexibility, executive decision making. So all of these things are things that people use every day. And these could be think of as cognitive enhancement or cognitive augmentation strategies. So there is nothing that prevents them from using these, just like you use your computer, your calculator, and all the things to do operations that usually done primarily on your own brain. So there is the possibility of doing that in health. And I don't see any immediate threat for them doing that. So that would be my answer. So I think the market is probably going to take advantage of it at one point or another. And healthy people are welcome to use these. And even as we look at people like me that are very old, we all suffer some level of cognitive decline as we're aging. So even though we may have some healthy aging, so this would be a very large population that is only getting larger that will benefit from having this type of cognitive enhancement tools.
Just adding to that, and thinking about this question, I think what are the main challenges or difficulties that we all have as healthy adults that tend to get decline and these abilities get worse as we get older? And I think of two things, and one is multitasking, which everybody does here and everybody does poorly. And also memory, defining memory, and those are two areas of cognition, and I can imagine people being willing to cross the barrier of saying, if there's devices that exist that can help me navigate my busy day more effectively, and not lose track of where I am or what I'm doing or why I came into this room, which is a common challenge for aging populations. It's a failure of prospective memory, kind of keeping track of what task I'm doing now, what information do I need to do this task, the way that I get disrupted by something, tend to that, and then where do I come back to? Right? If there are devices that can help with that can restore basic cognitive function that people can identify being able to do this a lot better when they were younger. I can imagine them taking a plunge on more invasive interventions there, and then also, of course, memory. Think of extreme cases of maybe early, onset Alzheimer's. That's the major fear for most folks, one of the most debilitating cognitive diseases that exist. Well, if there are devices that can be implanted in our hippocampus or other areas of our brain that can help to regulate our memory function and tickle us in certain ways that help us access information that is in our brain, but we can't naturally access on our own anymore, but the devices can help us do that. That is a profound way to restore key, human functioning, healthy functioning. So it's I think those two areas that I could see they're being, if tractable, effective solutions hit the market, that people will be interested in.
We have been running for years a research line about how to enhance the interaction abilities of healthy individuals through the use of BCIs. And maybe the most prominent example is our collaboration with the car manufacturer design. And they have patents, they have products that are using our BCI technology to do so. And it is not about replacing the driver, it is or driving by mental power, that people keep driving, but you can infer many more things about the state of the subject that the intelligent car can use that will make the driving experience much better, and you will feel a better drive. And we have been testing it, and it works. Then you are working, Donovan, on a project where we are attempting to decode brain signals that can have the power of us teaching our interactive device how to adapt to us in a personalized way. And that would be groundbreaking, that you, without needing to program anything, you are teaching your systems on the fly how you would like them to have it at any time. For the memory, though, I think that we have already the technology to help us. I cannot remember your name. And who are you? Which are the facts that I know about you? Which are the relations that we have together? We can have those technologies in glasses. There are prototypes of glasses that can do all that work for us, because it will be accessing our devices and pull out every information that I need in this context about you.
Okay, we are running a little tight on time, so we are going to move on to questions. However, I just want to very slyly reveal these questions that people could potentially ask regarding Homo Deus, which is Yuval Noah Harari's theory of the next technologically altered Homo sapien. Tie that into all stuff. You got crazy stuff going on. The other question being AI 2027. We all heard about it. LLMs might take over. Okay, let's go on to audience questions. How we could do this is that if you're on that side, you could start lining up in the hallway. If you're on this side, this hall, and we'll just pass the mic back and forth. So yeah, if you have any questions for our lovely panelists, go ahead and start lining up.
Line up right here.
He's a bit immobile, so if you can start.
Okay, yeah, we'll let this lovely fellow have the first question. Here you go. What's your name?
Lazy people.
Hi there. I just want to say thank you all so much. It's been very insightful. My name is Nick. I'm a first-year MBA student, and I broke my back 2.5 years ago, and that forever kind of changed my life. It gave me a new purpose to try to help commercialize some of the technology that y'all are working on. And a couple weeks ago, I was at the Unite to Fight Paralysis Symposium, where it's on science and advocacy, really taking the patient's lived experience, and kind of want to get y'all's insight on how y'all do that, just to get to the issues that are meaningful to your patient population, but also thoughts on combinatory trials. A lot of these, scientists and clinicians are really focused in their silos, but how are y'all trying to reach out to other people in the same domain, but with pharmaceuticals to try to cure a really complex problem?
Yeah, I can address that. So, speaking from the perspective of Neuralink, we do have a consumer advisory board. It's a formal board consisting of people who might be helped by future technologies, so people with paralysis, either paraplegia or tetraplegia, people with blindness and stroke, some of the other things that we're looking at. And so that's a board that meets regularly, and the company takes real input from those people about what the design interface should look like, what kind of needs they have in their daily lives, caregiver needs. I mean, I've actually gone out and conducted, caregiver interviews. In my work as a surgeon, I don't get to do that. I usually just treat the patient, and then I see them back in the office for follow up, and that's it. But I've learned a lot about how much software injury, for example, can really affect someone's life and the life of those around them, right? Who people may leave their own jobs to take care of that person, and lose their own health insurance and all that. And so it's very complicated. But I think if you're developing BCI technology, you have to know about that stuff. You have to know about those user needs. One of the interesting challenges, which gets to a little bit of what you asked, is that in order to get this technology, commercialized technology, through the FDA, you have to demonstrate a benefit at a reasonable risk, right? And in order to demonstrate benefit, what does that mean for BCI? We're all talking here about how great BCI is, but how do you quantify that? You're not really, in most cases, doing disease-modifying therapy, right? You're not really going to change the fact that someone's had a spinal injury or had ALS or any of these other disorders that we're talking about, but it's an assistive technology where you're unlocking new things and new abilities in their lifestyle. And so, it's a real challenge actually breaking new ground scientifically in order how to actually measure that in a clinical trial, in a pivotal trial. No one's done that before for a medical technology. Most medical devices are treating a disease instead of being implanted assistive technologies. And so, there's a whole effort that we have that's partnering with some major rehab institutes to figure out, like, how do we measure that? How do we actually, and part of that is talking to patients and families.
So how do you go about learning new stuff about the brain? Because all of the information, like studies I've seen, tend to be, we have a sample size of people with something different about their brain, like epilepsy, like severe epilepsy patients got their two hemispheres detached as a fix, and then they decided to study what that did, what the two hemispheres were doing, talking to each other. But it's like, do you only find out because there is something different about this group's brain? How do you go about finding new information about the brain?
What a great foundational question. The answer is all of the above in many, many ways. You described one way is through clinical approaches where you have patient populations or patients with diseases or with accidents. I can, for example, say in the memory sphere, we learned the most about how human memory works from one individual over the past century. And his name was Henry Molaison, known as patient HM. He had intractable incurable epilepsy. And at the time, the surgeon decided the best procedure was to remove the part of the brain where the seizures were starting, and that part of the brain was the hippocampus on both sides of the brain, plus some other areas. But they took out his hippocampus. It stopped his seizures, but it left him profoundly impaired the rest of his life. He had severe anterograde amnesia, which means he couldn't form new memories. And he was studied for 50, 60 years. And we learned so much about the neural systems that support different types of memory. We learned associations about episodic long-term memory, semantic long-term memory, as I was saying about facts that we know about people, and about working memory or short-term memory. These are supported by different brain systems. And we learned that through an unfortunate accident that befell the scientific community that we took advantage of in a respectful and mindful way. That is one approach to learning things. Another way is what basic science researchers are doing, is not studying patient populations, but studying the healthy brain and trying to map out as clearly and precisely as we can how normal, quote unquote, normal range functioning works. and to better understand how different neural systems communicate with each other, coordinate to provide a myriad of high-order cognitive functions. And so those are like two ends of the spectrum, studying brain damage patients and studying healthy populations, both inch us forward to having a better model of healthy disease state brain. I'm sure, of course, there are many other approaches, but those are the two ends of the spectrum.
Thank you.
All right, my name is Jules. I'm a sophomore biology major. I actually had a Neuralink specific question about the Blindsight project. I was wondering what are the kind of challenges y'all face right now in restoring vision, and what, if you had to guess, is like the timeline until we have technology that can mimic accurate vision.
So he's referring to a program which is a stimulating BCI. So instead of recording, it's stimulating the visual cortex, so the occipital lobe, to recreate functional vision. That's the project. And that has received FDA breakthrough designation as of last year. It's something our company is working towards very avidly, and hoping to start trials sometime in the next year or so. The challenges with that really involve the fact that some of that work needs to be done in humans before it can be understood. So, you can't, there's no real animal study you can do, even if you implant an implant in the visual cortex, to ask that animal, even a monkey, what do you see, and how does that compare to normal vision? You really can't answer those questions. You can answer some simple questions like, hey, which the company's actually done, and labs at various places have demonstrated where you can stimulate a part of the visual field mapped onto the visual cortex and make it look like a flash of light, right? In a certain, so the monkey grabs that area. So that existence proof, we know that works, but in terms of replicating, a highly, complex, dense information field on the visual cortex, a lot of that, will need to be figured out when we actually do the first patient. And so that is one big challenge. There are challenges. Well, if you simulate in a grid, in a bitmap, let's say you have 128 pixels, right? 128 electrodes, and you're stimulating in a pattern to match, some bitmap that a camera captures and puts onto the cortex. Does that look like an object in our visual field? What is the psychophysical perception that we have of that? Some of those are really unanswered questions. So and it relates to this question of consciousness, right? And how do we as conscious minds perceive something like a visual field, the object in that visual field. So you get very deep very quickly into these questions, and some of them are unanswered science. And get pretty philosophical actually. So the engineering technology is one aspect, and there's certain configurations of the electrodes that need to be changed in order to make the stimulation function work. But fundamentally, I think that the bigger challenge is how do you map that onto human perception?
Hey y'all, I'm Anna. I think most of you know me. I'm a PhD student at Hudson. My question is really broad. I'm asking if you guys were a PhD student today, what kind of question would you ask for your dissertation? And the reason I'm asking about this is because I think you work on a lot of exciting stuff. So I'm trying to get a sense of what is the most exciting, impactful question that is also feasible to do so that people here know what kind of projects are the most impactful and that they can focus on and actually get done. Yeah.
Are you trying to change?
I'm getting ideas. I'm trying to get ideas.
Well, if I can answer it, some of our work, because it's non-invasive, lends itself more for contributions from undergraduates. So we usually have a dozen undergraduates at any given time working with PhD students and postdoctoral fellows. And they can contribute a lot in these kinds of contexts. It's not, it is something that is reachable to an undergraduate to make a contribution. And so if they can also contribute participating, it's volunteers in some of the ongoing projects.
So I was just trying to think about for the new students that join my lab, what projects we're going to have them work on. Because generally that's what I'm most excited about right now. So I think what I would pick is something related to synaptogenesis and how to steer synaptogenesis with some neuromodulation therapy. So synaptogenesis is something that happens naturally during development. So neurons kind of learning to connect together and pruning those and refining those connections. That's something that happens in development and at certain stages of development. So you can imagine that it could be relevant to things in early development, but could also be relevant to promoting new connections that maybe have been lost in the disease state. Can also be used for developing better in vitro models, like in brain organoid environments, if you want to create like networks of organoids together to try and promote those sort of connectivity patterns to mimic what we see in vivo, to have that as a platform. I think there's lots of things where being able to control this mechanism would be exciting. So you can already see that I've thought about the different funding agencies that are going to pitch this to from the application. But yeah, I think that's what I would think.
Yes, so my lab is like a tool development lab, so we probably won't ask like neuroscience questions, but we probably would think about like what would be the technology that can give like a non-invasive based like both recording and stimulation for specific type of the cells or anywhere in the brain, so kind of in those directions.
All right, and as we're a little limited on time, this will be the last question, so take it away.
All right, thank you. Thank you all so much for being here. I'm Kailash. I'm a junior, double major BCE in neuroscience. Though my passion is primarily in like brain-computer interfaces and computational neuroscience, I have like a question on a different side of this whole conversation. So this is about material science engineering. To what extent do you think we've reached a peak? Do you think we're maxing out on the chemical, all that knowledge when it comes to implants and even surface level stuff that is non-invasive? Are the materials that we're using the best that we can reach, or is there really a big scope for improvement there?
What about since I'm a material scientist, I think there's certainly a lot to still like needs to be done, right? So for example, the non-invasive aspects, I think we now like, for example, we have like good low impedance, long-term stabilities, and good adhesion for the wearables for recording stimulation. But then there's something much more, like it's probably best to be like a sweat resistant if we are wearing it like every day, and everyone can have sweat. And then there could be like a mode that like a breathable, right? Like then we could have a good breathing. We don't see any of the redness or like a most comfortable aspects, and the same for like invasive as well. I think people certainly has been doing a lot of like studies on the biocompatibility. Like I guess they're using like now like very soft electrodes, and that's certainly improves the biocompatibilities. And then I guess the next question also like can we record like for 10 years, right, or like or 20 years, and still have a very good, don't get the any of the glial cells and or the high quality recordings and stimulations, and yeah, and also like in terms of like the basically like immune or other type of response. Yeah, I think there's certainly a lot of things that could be going on.
All right, thank you guys for your questions, and let's give a nice round of applause for our panelists. some very insightful things from our panelists, and it was really exciting to get to see all that y'all said from your backgrounds and stuff. Quick plug, March 28th and March 29th, we will be hosting our first Neurotech conference. It'll be the largest conference in the state of Texas for neuroengineering. And so if you are interested, we encourage you to sign up with the QR code. It's 9 a.m. to 5 p.m. There's going to be lunch, details, and lots of other stuff with registration. But it'll be a great time. I'll leave it up for a few more seconds. All right. And also thank you very much for all of our departments, laboratories, and companies for supporting Longhorn Neurotech, our projects, and being able to host awesome events like this for them. Even though they're not here, let's just give them a round of applause. Thank you for the morning. All right, well, thank you all so much for making it to the forum, and hope you all have a safe rest of your night, getting safe. And Longhorn Neurotech members, see you on Sunday.
Because you can't tell from the corner.
Picture.
You start thinking about it. But definitely this is in the minds of everyone.
Take a picture of y'all really fast. Y'all want to stand up and just get together.
Is there a chair for you now? Take a picture of them.
Okay, and if y'all want to go up there as well.
That's the highlight of the speaker. I was like, yes.
All right. Thank you all live viewers. I'm going to end the stream now. Bye.